Welcome to ESD School, brought to you by ATRACT. Don't forget to subscribe to the channel so you don't miss a single episode. Enjoy the video.
Hi everybody, we are here for one of the new part of the ESD School, which is the complete procedure. In this case, we will see only the endoscopic view of the procedure, which was a rectal LST ESD during 21 minutes, and I will try to comment all the things. It could be a tool you can use as an observation tool, like if you had the chance to be with an expert to see a complete procedure. We choose a short one. Fortunately, you will not have to spend 2 hours seeing this procedure, but in 21 minutes you will see all the steps of the procedure, and I hope you will have an overview of the whole procedure of ESD. So here you can see the different parts of the ESD school we want to share with you, and in this one we will see a full-time procedure like an observation. So the difference with the real life is that you don't see my hands, you don't see how we proceed, you don't see the nurse, but at least you will see all the steps and all the difficult part of the procedure. And it can be also a training for the endurance you should have for this kind of technique, because the procedures are longer than what we are used to do with the conventional techniques. So here we are. This is the lesion, which was a non-granular LST with two different components, a really flat one, relatively thin, and another part which was thicker. I really think that the lesion was more a sur-elevated LST non-granular than a depressed one, a pseudo-depressed one. The pseudo-depression here is due to the fold, but not really to the lesion itself that does not go under the plan, under the layer. It stays every time above the mucosa, but with different shape and different thickness. So we will use here the ATRACT strategy. You will see every steps we will discuss, but at least to have a schematic view of the procedure. During the ESD, the angle will go down. We will stretch, tighten the device to improve the field of view, increase the tension, and therefore achieve the resection here once again in 21 minutes. So first, in the strategy, the more difficult part probably here is the oral side of the lesion. One option could be to do a retroflexion, but in fact it was not very easy in this rectum. So we choose an approach in direct viewing with an injection at the oral side, which is important because you will turn the lesion by injecting at the oral side. You will turn it front to you, and therefore, as we discussed in the episode about injection, you will have the mucosa facing you with a 90 degrees angle face to you, and it will be easier to have a deep incision with strength if you do something that face you instead of doing something that goes down, like the downhill of a mountain. Here you increase the size of the oral side in order to face you and to have a good incision and a relatively good access to the submucosa. So first you do the small hole, which is very important, a very small hole. Here again, a small hole you inject into, and then you go from this hole, and after you slide with the device at the top of the mucosa with the needle in the submucosa and the ceramic at the surface of the mucosa. By this sliding you will get an incision everywhere at the same depth. You will see it again. So here the scope control was not very good. It was difficult remove my hand from the scope because the position was not really stable, but and therefore I fixed the lens of the device, and I choose to move the scope itself as a tool and not only the knife. When you go in a valley like this, you should inject again, because it will at least I try to remove the valley and make more heel shape that is easier to cut than a valley where the knife has difficulty to go. So here it was difficult to go from the right to the left, so I choose to change the side at the opposite edge, and then it was easier to go there and to join. But once again there is a valley, so we will inject, because if we don't inject, the depth of the incision will be less important on the valley than in the other part of the heel. So it is better to inject again here, create a heel and not a valley, and therefore go to the opposite wall. It is sometimes, when you are a beginner, needed to go outside to change your vision, to be sure you are not going to the lesion, but you are going to the remaining incision in order to do your circumferential incision. So when you are well, you can do immediately your trimming. It means doing a second a second way in the incision in order to improve the size of this incision and make space that will make the end of the procedure easier. Once we have done this, we have a 5-hour channel scope, so it is easier to slide from the area we see to the upper left corner. I re-inject, and once again we slide at the top of the mucosa with the needle in the submucosa and the ceramic at the surface, and I check the position where I'm going, and I go to join my incision. It is always difficult to join an incision because at this point injection is less important, so sometimes you have to pass several times at this point where you should join your different incision. I will inject with the knife directly because I'm in the rectum and it's easy to do it without risk because the submucosa is thick, the muscle is thick. Once again you have a valley here, you inject to create a heel. It stretches the mucosa because there are more liquid under the mucosa, so the cushion is better, and if you have more tension in the cushion, the mucosa is stretched and it's easier to get access in the submucosa when the mucosa is stretched, because the knife enters more easily in this stretched mucosa than if the mucosa is floppy without injection in the lesion. So once again we inject, we stretch the mucosa, and then we slide in order to join the second. Your aim is to get a round shape because if you get this round shape, all the vectors, all the force are going to the center of the lesion, and then it opens the space of your incision. You will see it in the drawing on the left soon, because our aim is to have this quite round shape of incision like the drawing on the left, and not the right one where different vectors are not good. Once we get this, we remove the scope, go with the device on a clip with the first point of the traction device, which is the oral side point, the fixed point, and we will fix it on the edge, on the oral edge of the lesion with a conventional clip. We should say that the clip that turn by themselves, or you can turn by yourself the clip, are easier to use in this very difficult work, trying to catch the loops and fix it. It's better to turn by yourself, and the clip that allows to turn by yourself are possibly better than the one that should be turned by the nurse. So the second loop here it's the blue one, very small, because it's once again an active point. We will be able to tighten at the end of the procedure. So we catch it with a second clip, go to the oral side of the lesion, try to avoid losing the second point, and then we open and catch the oral edge of the lesion, the anal edge, sorry, of the lesion here, and fix it. So we have 2 points fixed, one at the oral side and one at the anal side. Now we will fix the 2 lateral points, which are the green loop and the purple loop. You will see it. So 2 additional clips are needed. Always the same. The one that turn by themselves are better, because it's easier to catch the loop and to turn. So here we will catch the green loop. Try to avoid catching anything else, and go to the left part here and fix it on the edge. So you should catch it not too deep to avoid catching the muscle that could make the resection more difficult. The aim is to catch the mucosal flap, and the trimming you did at the beginning is very important, because it makes the flap free from catching the muscle when you will use the clip to fix the loop on the edge of the lesion. So here we will have a multi-traction strategy with 4 cardinal points fixed on the lesion, and then we will create the left end by a control traction going to the opposite side of the colon. You will see just after. So I try to catch the loop without catching the active system, the tightening system, you will see. So we release the 4th clip, and now we have the 4th clip fixed at the 4 cardinal points and a rubber band at the middle. It seems complicated, it is a little complicated to fix on the edges, but you will see the benefit. So now we catch the rubber band, go to the opposite side, deflate as much as possible in order to create a fold, and if it's not enough, we will catch again, but here it was okay, and you can see the exposition. By inflating the colon, you really create a triangulation with a left end that stretch the mucosa and that stretch all the points of the lesion, the 4 cardinal points. So ESD will begin now. It seems very easy now, thanks to the traction, but in fact the scope control was again not very good, and I could not adjust the length of the device because as soon as I removed my hand on the scope was not stable. So in fact I should stay catching the scope itself and fixing the length of my device, which is not the more effective probably. If you can find a position where the scope is totally stable, it's sometimes easier to adjust the length of the knife with a continuous movement, and after you try to follow the cut line. The best cut line is the one that is relatively close to the muscle, because close to the muscle you see the muscle fibers, and therefore you can orientate yourself, because when you see the circular layer you have a perfect knowledge of the position of your scope. Are you perpendicular to the circular layer? It means you are going straight. If you can see the muscular layer, it's better. And the other benefit of being relatively deep is that you have a deep margin, so it's better for malignant lesion. Here we don't think that it is malignant lesion, but it's better to have more margin on the vertical point of view. And the last point is that vessels come from the deep part of the muscle, and after they divide in many branches. So the more deep you are, the less number of vessels you will have. They are bigger, but you have less vessels, and it's easier to manage and to control few vessels with a large size than many small ones that make oozing, or so dissecting very close to the mucosa is really more difficult than dissecting very deep close to the muscular layer. Here you can see the vessel that is dividing in the submucosa, so coming by a large trunk from the deep submucosa, and after dividing in many branches that are thinner but that can bleed a lot if you damage them. So the best probably is to go deep and to control this kind of vessels. I like to dissect in the two sides of the vessel, so on the right, on the left, I re-inject in order to have space to place my forceps if needed, and after I will coagulate with the tip of the knife using swift coagulation. I'm still using a lot the swift coagulation for dissection when I see a vessel, and as soon as there is no vessel, I like to use cutting current like endocut because it's more precise than swift coagulation, where you have a kind of ball of fire around you, so you are less precise. So when I see a vessel, swift coagulation. When I have no vessels and the submucosa seems free of vessels, I use cutting current because it's more sharp, more precise for me, and I like to be precise. It's finally faster. We learned it from ESD for the recurrences, because in the fibrosis it's very difficult to use swift coagulation because the space is very small, and then we used a lot the cutting current, and after this experience we change our practice to use a lot the cutting current and less probably the swift coagulation, except when a vessel is visible. I don't change for soft coagulation or force one because it is not enough powerful for the bleeding that comes with a knife, where the surface of coagulation is very small. So here you can see that we use the new mode from Olympus called RDI to less be disconcentrated, perturbated by the blood, which is red. By using this new mode, you change the color of the blood, and also you have a contrast between the point that is bleeding and the other point where the lake of blood is present. So you have more red in the area which is actively bleeding and less in the lake of blood, and these contrasts allow you to see better the point of bleeding. After we try to dissect. You see that we are close to the lateral point, where there is a new clip with the lateral loop, which is tracting the edge. So here we have the scope, which is a 190 Ti Olympus scope, and the main benefit of this is that the flushing function is going on the axis of the device, so we can stay at the same position when there is a bleeding. The flushing is going to my knife, and therefore I can wash the area which is bleeding without moving the knife to go at the good position. With the non-therapeutic scope, usually the flushing function is coming from 8 or 9, and therefore you have to move your scope to wash and after to go back with the device. With the dedicated therapeutic scope, it's really easier because the flushing function is going to your knife where it is bleeding, and you don't have to move. So here we see that the tension is less important. We need a little more tension to increase the space, and then we will use this adaptive traction device by searching the loop of tightening, not this one, the long loop which is there, and then I will catch this loop with a forceps, which is a rat tooth forceps, conventional one, and then we will tighten the device by stretching the adaptive loop, and it will stretch all the points of traction together, and you will see with inflation that the tension is very strong and the lesion wants to go. So the main effect of this is that you stretch a lot the submucosa, and therefore in fact you reduce the shape by traction. If you tract something to the opposite wall, the submucosa is stretched, and therefore every strike from the knife will cut more fibers because they are concentrated by the tension and by the force of traction to the opposite wall. So in fact you will increase a lot your speed because all the fibers are tightened, are stretched, and every cut will cut more, and therefore the surface will be cut in less duration, so in less minutes. And in fact with this kind of device we increase our speed in between 2 times and 3 times depending on the lesion, but when it is an easy lesion the speed is really increased a lot in our series, and it also allows to deal with very difficult lesion like appendicular ones, ones in the ileocecal valve, or for example in diverticulars or fibrotic areas, or all this ESD that were quite impossible, and thanks to this very strong traction that is adaptive when you need, it makes this difficult case feasible. So 2 main advantages of this strategy: making the easy cases or the relatively easy cases faster and therefore more compatible with the endoscopy schedule, because as you know, one of the limitations of ESD is the duration of the procedure. If it's very long, we could change for piecemeal EMR, but here in 20 minutes we could remove this 45 by 4 centimeter, 4.5 by 4 centimeter lesion, and the whole procedure, which is here, was 21 minutes. And after we took the forceps to catch the clip which was fixed on the opposite wall of the colon, in order to remove the lesion and stretch it on cork to send it to pathology exam. So it is very easy to remove. There is no resistance. The clip have no real force when you fix it and stretch it, and when you pull back. And we had I think we did more than 1,000 cases now of traction with rubber band or something, and we had only 1 bleeding on the point of the clip, but never any perforation on this. So here the procedure is finished. We went back for hemostasis, but as you see, the lesion was resected en bloc, R0, and finally it was high-grade dysplasia, completely removed, R0 on the vertical and horizontal margin, and it means a curative resection, totally curative, with a next control of colonoscopy in 3 years in French guidelines, and in between 1 and 3 years depending on international guidelines. So I hope this procedure was nice for you, and you could learn some points in a real clinical case. You can see all the different episodes about injection, incision, trimming, traction, everything, management of adverse events, but we will also try to give you some complete procedure in order to have also the whole procedure, and to be used to the strategy from the first to the last fibers. I hope it was interesting for you, and hope to see you soon in the next episode. Best.
Thank you for watching. If you found this video helpful, please give it a thumbs up, subscribe, and share it with your colleagues. Until next time, this is ESD School by ATRACT.